Hello, everyone. Welcome to the final webinar in this academic year's series, which is about Parkinson's disease and housing design. Don't worry, the next series of webinars will start again in the next academic year from September, and that'll be advertised very shortly. My name's Adam Ferry. I'm an occupational therapist and one of the directors of the OT service. Today, we're going to explore activity analysis and the impact on occupation. I think that's really important with any webinar that we do, given that we're occupational therapists and it's our core skill and our USP. But I think within this webinar, we're going to pay particular focus to the activity analysis and home modifications and design. I'm going to try and be as specific as I can be around some of the things you're most likely to see for someone with Parkinson's, whilst accepting that everybody's completely unique and different. We're going to reflect on using home modifications to enable occupational engagement. And we're going to consider the activity analysis of toileting specifically, providing insights into design potential. So as much as we are going to look at the home generally, this webinar is being delivered on behalf of Closomat, so we are going to look in slightly more depth, as well as that, on toilet hygiene and how we might be able to resolve some of those challenges. What I don't want to do is presume that everybody here knows everything about Parkinson's or even knows what Parkinson's disease is. Because the webinar is quite widely circulated, I want to make sure that we've got an overview of Parkinson's and we understand it, so that we're not missing out anyone who might be new to the area or to the condition. So bear with me if you are already an expert in Parkinson's. So what is Parkinson's disease? It's a progressive neurological disease that leads to movement disorder, so it affects how our body moves. The cause is largely unknown, so it means the condition is idiopathic, but some research suggests links to air pollution, pesticides, as alongside family history and genetics. But there isn't one specific understood scientific reason for one person having a Parkinson's disease over another. And it's from a scan perspective, so from an investigative perspective, it's about the presence of Lewy bodies, which exist for Parkinson's in the substantia nigra, and that impacts on dopamine production. Now, the Lewy bodies you might be familiar with from a dementia perspective, and they're exactly the same, the Lewy bodies, but they're in different places. So different places of the brain could lead to Lewy body dementia or to specifically Parkinson's, although we will talk about within this webinar how there are similar and different symptoms and presentations for someone with Lewy bodies or Parkinson's or even Parkinsonism. But essentially, it's the presence of Lewy bodies in that particular part of the brain and an impact on dopamine production. So why is dopamine production important? So a little bit here, going back to when we were studying at college or university around Huxley's sliding filament theory. I'm not going to go into this in an awful lot of depth, but I think it's quite interesting and important for us to understand the physiology behind the neurology and the changes it makes to the nerves and how signals flow from nerves to muscles. So you can see there on the image on the right, that's the top image is normal dopamine production. Dopamine supports the transmission of a signal from the neuron to the muscle cell, to the muscle fiber. So because for Parkinson's, the Lewy bodies in that particular part of the brain inhibit dopamine production, you're getting a less efficient flow of signal down the axon and into the muscle fiber. It's why with Parkinson's disease, one of the most common symptoms is a tremor, say, for example. It's anything that impacts on motor skill, on muscle movement, and why with Parkinson's, you often get what's called cogwheel rigidity. And to my knowledge, one of the things that's unique with Parkinson's over something like a Lewy body dementia, that cogwheel rigidity, which gives that more, if you imagine a muscle being moved, but then not being able to move smoothly, essentially. So as if it's going over a ratchet. And it's largely because of the lack of presence of dopamine in that part of the chemical process. But if you want to know more about that, I'll leave you to explore that in your leisure. Some important statistics. So 1 in 37 people living in the UK today will be diagnosed with Parkinson's disease. 153,000 people in the UK already have a diagnosis of Parkinson's disease. Only 1.2 of people diagnosed with Parkinson's are under 50. I think there's sometimes a bit of a perception that that's higher, but actually it isn't, because the vast majority of cases are diagnosed in the 70 plus age bracket. Now, that doesn't mean that those people aren't having symptoms for a period of time before that, maybe even significantly before that, and haven't just gone to seek help. But I think, like I say, there's often a misconception that there are a large number of young people, especially men, with Parkinson's disease. Whereas 70 plus, although that's still young by modern standards, it's not as young as sometimes we think. And for an unknown reason, men are 1.4 times more likely to be diagnosed with Parkinson's than women. And I just want to clarify that Parkinsonism is not the same as Parkinson's disease. Symptoms can be the same or very similar, but there is no Lewy body present in the brain. It's from another identifiable cause, such as a stroke, dementia, head injury, or toxin exposure. So if somebody had a stroke and that had impacted their motor control, so they had a tremor, say, for example, or they had other features that were very similar to Parkinson's, the diagnosis still would not be Parkinson's. They may have Parkinsonism because it's a reflection of a similar or same symptoms, but from a completely different cause. So just bearing that in mind. It doesn't necessarily change, however, some of the things we're going to talk about around home modifications or equipment adaptations, because we're, as occupational therapists, we're wanting to have an impact on the issue which is impacting itself on occupation. So we're not overly interested in that point in the diagnosis, other than how that might change or alter our clinical reasoning. So, for example, somebody could have Parkinsonism in their medical notes or their GP records or something like that. But Parkinsonism itself isn't necessarily going to be degenerative, whereas Parkinson's is. It would be looking at the identifiable causes for the Parkinsonism and trying to work out whether some of the things that you were going to put in place were about future-proofing for disease progression, the disease that's causing the Parkinsonism, or if in fact it's something that's going to remain stable and present for the duration of that person's life. So it's important from a clinical reasoning perspective or an evidence-based perspective, but isn't essential necessarily to the now and then recommendations. Some of the symptoms, some of the motor symptoms are bradykinesia, that's slow movement. Like I talked about very briefly within Huxley's slide and filament theory there, rigidity and postural instability, so balance, coordination. And non-motor symptoms can include depression and anxiety, often linked to social isolation rather than as a direct impact of the disease itself. Sleep disturbance and cognitive impairment. So there are associated dementia with a diagnosis of Parkinson's disease. Now, Parkinson's has 5 clear stages. And the reason I've identified the 5 at this stage in the webinar is because I just want to reflect later on the impact of legislation on what stage somebody's at and whether that matters or not in terms of that idea of a disability having a moderate impact on somebody's life, given, say, DFG criteria, for example. So I wanted just to outline here what the 5 stages were. So stage 1, there may be a mild tremor and movement symptoms on one side, some changes to posture and gait, but no big impact on function. The person at that stage might not even know they have Parkinson's, but but it is likely that they do, but it's having no impact on life. In fact, there are now pre-Parkinson diagnosis stages where it looks at, and I haven't identified them in here specifically because that we would tend to not be involved with the person at that stage. But they are those three pre-diagnosis stages are where the person goes from completely normal function, completely normal physiology and presentation to having extremely mild symptoms and going through that diagnostic process. At this stage, that 1 to 5, the likelihood is at stage 1, they already have that diagnosis. Stage 2, tremor, rigidity, and other movement symptoms affect both sides of the body or the midline. And mobility and postural changes can become more evident. So the likelihood is symptoms are starting to have an impact on function and engagement in occupation, but maybe not to the point where the person is unable to be independent. Stage 3, loss of balance is the hallmark and falls are far more likely. The disability at this stage is classed as mild to moderate. So bear that in mind. At stage 3 of the progression, disability is classed as mild to moderate. And I want us to reflect a little bit later on where that leaves stages 1 to 2 in terms of the legislation. Stage 4, symptoms are fully developed and having a significant impact on functioning. They may be ambulant, but likely with an assistive device or with support. And stage 5, the final stage, lower limb rigidity inhibits mobility. The person requires a high level of support for functional tasks. And there may well be some nursing needs within there as well around swallow, hygiene, oral intake, that kind of thing. So I want to have a quick look at some of the most common issues that you might find within an activity analysis before we explore this from a more general occupational perspective. So you might, from the motor components, you might find muscle stiffness, so more rigidity. You might need to think more about which muscles are agonists and antagonists within certain tasks, and where the tension is, in order to coordinate or manage or compensate within tasks for the person. Trunk stability, which leads to impaired balance, so some sitting balance through to standing balance and mobility balance, so much more dynamic. Can the person correct to their midline? There may not be an issue with the person knowing where their midline is, but maintaining that midline in sitting or in standing might become more challenging because of other things that are going on. Altered gait pattern, stride length and speed. So we know that's a very common symptom within motor components for someone with Parkinson's. We often see that shuffling gait, and we know that somebody who uses more than 8 turns to turn 180 degrees is much more likely to fall from a NICE guidelines perspective. So if the gait becomes much more shuffly, the risk of falls becomes significantly greater. Inhibited initiation, so that ability to initiate a task, and I certainly see that a lot. So particularly in something like standing, so the person might get to a certain angle or a certain standing posture and then not be able to initiate the next step or initiate the next task. And that's not in the same way that you might have neurologically from a stroke, where it might be about the brain understanding what comes next. It's the actual motor component of muscles losing that ability to receive the right stimuli to step or to move or something like that. But it's happening in a different way here to someone with that who has a stroke. Freezing, we see that a lot through threshers and any surface changes, and we'll talk about that in a bit more depth moving forward. Reduced coordination, particularly bilaterally, so when you're moving across the midline and trying to coordinate with right and left hands, and inhibited fine motor skills. So dexterity becomes much more difficult. Non-motor components, so someone getting fatigued much more quickly, slower processing, so someone looking like they're taking longer to understand what information is being provided. Anxiety, often related to depression, social isolation, like I've said before, but also falls. You're aware of that post-fall cycle where once somebody has fallen once, the anxiety associated with that has a cyclical effect. It's called post-fall syndrome. So where the person does less because they think that's going to reduce their risks, but actually it increases risks in the long term, because when they then do have to get up to do something, they're in a much higher risk position. And bladder and bowel dysfunction. So we're going to start looking more specifically about when we're assessing somebody with Parkinson's, what sort of questions do we need to know? It doesn't mean we need to ask all these questions, but when we're conducting our assessment and thinking about activity analysis, what is it we need to understand about what that person does and how they do it? So using the toilet, I'm going to focus on that specific task. And within this slide, this is about the mobility. So how is the person getting to and from the toilet? Now that might seem really straightforward answer, but are they walking or not? If they're walking, what mobility aid are they using, if any? Do they furniture walk? Do they hold onto door frames? Do they use anything to correct their balance at all? Where is the bathroom and the toilet situated? So is it or do they have one on the ground floor? Are they having to go up and down the stairs to be able to use it? In the northeast, there are still a lot of old mining communities where a toilet is still outside, and a lot of those homes have had toilets and bathrooms stored indoors. But it's really important in those situations to know, well, where is it? How do you use it? How are you getting there? Are there any environmental risks? So trips, slip hazards, any raised threshes, what are the walkway widths? These are all the sorts of things we're starting to put together. What are their day and night routines? So when does the person use the toilet? How many times a day do they tend to pass urine? What's their bowel movement routine? What are their general patterns? So you can start to paint a picture of where the risks might be, or what you might need to do to support them, and how often are they making the journey. The transfer. So how are they transferring? So if they're obviously at a later stage of Parkinson's and they're using a hoist in one place, then they're going to be, what are they being hoisted to? How is that being used with the toilet? If it's a wash dry toilet, how is what they're using over the toilet impacting on compatibility? But I don't just mean how does it go over the toilet, but I mean how is it affecting the wash and the dry? But if it's a standard domestic toilet, just how is it being used? How is the person getting then off it to manage, or how a carer is getting the person off it to manage their personal hygiene? Is assistive equipment in place? And if so, what? How is it being used? What space is available for transfers, either now or in the future? It's important for us to look at where the toilet is within that space, what would fit around it if the person's currently ambulant, where are the pipes positioned behind the toilet, what's boxed in, what isn't, just so we can start to paint a picture again of, if the person needs it, is it going to work? And then moving forward, how is it going to continue to work for them for the next however long they're in that environment? What's the design and height of the toilet? So how are they going to get on and off that? Don't assume just because somebody can get off their armchair that they can get off the toilet. Very different heights, very different transfer. Toilets, domestic toilets anyway, don't tend to have arms to be able to push through as standard. And we'll come on to that a bit more later when I focus on the standing task. And what's their posture and positioning like, both in sitting and during that transfer. In terms of clothing, does the person fully remove their lower half clothing? Do they just drop trousers to the ankles? Do they maintain the trousers or at their knees? Does a man stand to pass urine, or do they sit? How is anybody using and manipulating their clothing to use the toilet? And that links then to what type of clothing do they use? And we don't want to make significant changes. It's important that the person feels comfortable and the person wears what they're comfortable wearing, but there might also be suggestions we can make to make this part of the task more simple and with reduced risk. When they're fastening and unfastening materials, can they grip them, manipulate them? Again, is that going to get harder with time, depending on what clothing that they're wearing and using? And when and where are clothes adjusted? Is it at the toilet? Is it when they're sitting down to the toilet? So as they're sitting, are they moving trousers down, or are they lifting dresses, skirts up, for example? Or is that happening somewhere else? Because those things play a big part in our activity analysis. If the person's already sitting or starting to sit, then that has a huge impact on their balance, a dynamic balance. We take that for granted sometimes, of how we adjust our clothing as we're sitting and then pull things back up or adjust as we're standing. It might be that that person can't achieve that anymore, and how you support them to do it independently is really important. Is the actual act of passing urine or moving your bowels, is it performed in sitting or standing? Make no assumptions. Are medications or procedures required to prompt elimination? So is somebody using, do they have a bowel management program, say, for example, if they are incredibly constipated and they use something to get their bowels moving? On the flip side of that, do the medication that they change, is that impacting on their toileting at all and how they move their bowels, or on their frequency of passing urine? They have any issues with the urgency or frequency? Again, what's their posture or positioning when this is happening? Someone's posture and positioning when they first sit on the toilet might be quite different to when things are actually happening. They might start to lean to one side, or they might adopt a different postural sitting position in order to allow this to happen more comfortably. And what's their awareness of all that? Do they do that naturally? Do they have to give it some thought? Is it quite, for most people, it becomes quite instinctive, but do they have any awareness of passing water and moving their bowels? Are they completely continent or not? And then the cleansing, which for most people, or certainly a lot of people, is one of the most important parts for them from a dignity perspective. So again, is it performed in sitting or standing? Make no assumptions at all on this. And what's their posture like when they're doing that? So again, will somebody lean to one side to get access or not? Or will they access from the front? Again, that will depend on male, female habits and just what they normally do. But it's quite important to be able to know those things so that we can make recommendations that aren't going to impact on them. For example, I've seen freestanding toilet frames being recommended to help somebody stand up, but they were so narrow around the toilet that the person could no longer lean to one side to get access to clean themselves. So that they were having to change how they managed that part of the task. And that change to management, that part of the task, was then having knock-on impacts. So it's really important that we consider those things. Now, some of these things aren't easy questions to ask, and they're certainly not things that we're just going to stand in the bathroom and watch somebody do necessarily, but they're things that we need to consider. Certainly when we're making recommendations, all of that consideration of what I'm recommending could also have a contraindication. It could have a negative knock-on effect, and what could that be? So what do I need to know about that person with Parkinson's to think, how do I manage this in a way that's going to have the best possible outcome? What tools and materials are used? So and can they get them? So where is the toilet roll being situated? For example, do they already have a wash-dry toilet? What are the person's existing habits and routines? Are there any space limitations? What's the likely impact on their reach, their grip, their dexterity, and their general ability to sit for a period of time? These are all things that feed into our activity analysis. So once we know these things, it paints a picture of the person's routines to allow us to make informed recommendations. And then that leads to what kind of recommendations we make. Now, some of these recommendations are not necessarily specific to Parkinson's. There are things that, because Parkinson's symptoms can be similar for other conditions, or someone could have Parkinsonism, for example, they're perfectly reasonable to consider for lots of other conditions. But I'm going to try where I can to make some specific reference to Parkinson's and explain why. So flooring I've put there first, and I put that first there for a reason. There's a lot of evidence around the type of flooring used for someone with Parkinson's and actually somebody with any kind of proprioceptive or vestibular deficit within their activity analysis. If a flooring is too dark, it can be perceived as a hole or an open space. And I see that a lot with some of my stroke patients as well. So it's important that you consider the colour of the flooring, but also whether it's patterned or not. For example, I've seen a number of bathrooms when I first got to see a client where they have been black and white check. Um, and that is incredibly challenging often for someone with Parkinson's because of the next point on that slide, which is threshes. So it's that perception of where a room or space ends and another starts. And then linked to that, the initiation of the step. And that massively increases somebody's falls risks. So if you consider flooring being dark and then being dark and say checked or mixed with another color, that person with Parkinson's will likely find it very challenging to understand where is safe to put their feet or not, and will then have an impact on how they initiate that step. So it's much more likely to encourage shuffling gait pattern or create that freeze where the person is wanting to go, but their feet won't move and are likely to go over the top of their feet and fall. So flooring that is neutral, isn't mixed with other colors. So it's a block color and runs through as much of that floor as possible, the better. Ideally, you don't want different colors or carpets or anti-slip flooring in every single room, because that maximizes the number of threshes the person has to deal with. Ideally, you want flooring that flows through that floor, minimizing the thresh and maximizing the chances that that person will not see anything that isn't there from a perceptual perspective. So it'll encourage flow and gait. Guardrails and banisters seems quite straightforward, and generally it is, but be aware that if dexterity is impacted for someone with Parkinson's, or if they have quite a significant essential tremor, it's how are you expecting them to grip them? Are there different types of rails and banister shapes that might best suit the person? So here I'm not really, I'm not trying to say to you, oh, consider banisters and grab rails. I'm sure you all do that anyway, but it's thinking of, well, actually, is there something that the person's going to be able to grip better if that's what we're doing? And are they in the right place? Lighting's really important for safety. I know there's lots of work we're doing around task lighting. We've got other webinars that we've done for Closomat in the past that are on their website around design and visual impairment. And the same thing stands, but not necessarily from a visual impairment perspective. It's more about that identifying of space with light. So task lighting, where lights are brought off the ceiling, you might have a ceiling light, which is the general light. And there's a lot of guidance around what the strength of lumen that should be. But putting lights, recommending lights on the walls, halving the distance between the light and the object. So the sink, the toilet, the shower, for example, the kitchen unit, increases visual acuity threefold, according to research. So the more you can light space through task lighting and stop lighting the whole room, which will also reduce shadowing. And again, reducing shadowing reduces the risk of the perception of a hole or of a thresh, a change in that floor surface. So the more you can use task lighting, the better, as well as obviously encouraging natural light. Assistive technology. So as we're all aware, assistive technologies are um, developing on a daily basis. So we have to keep up to date with what's available. Now we're all familiar with your standard fall sensors and pendant alarm systems, that sort of thing. I think we don't need to go into that in too much depth. But let's think, and I understand this thing I'm about to talk about is equipment, but let's consider something like the Rolls Motion Rhythm, which is a rollator walking aid, but uses built-in metronomes and laser lines to support that initiation of the walk. Things like that are really important for us to be aware of. So either we can make the recommendations ourselves in our report, or we can support our physiotherapy colleagues to be aware of them, to make them if it's specifically around gait and balance. We should be considering technology-wise things like environmental controls. We can use and justify Alexa-based technologies within DFG now, as long as it's part of capital spend on a project. And if it's not, I would suggest that that sort of technology is built into the authority's RRO, so that can be purchased quickly and without means testing. There are other assistive technologies that we'll talk about within independence on the next slide. And steps versus ramps is a really interesting one. And that you might all have completely different views on it, but all I've put it in there for is because we don't make the assumption that ramp is safer. And I've seen lots of OT reports where the person's immediately gone to ramping because they think, well, in the future, the person's going to be using a rollator or they might need a wheelchair. And that they might be absolutely right. But given the type of gait that somebody with Parkinson's has, if you consider that short stride, shuffling step, walking down a ramp is incredibly difficult. And in my experience, anyway, the risks don't necessarily reduce. In my experience, what's more likely to support the ambulant user anyway is widening and shallowing steps so that they're able to step with their walking aid onto that step and then move from there. So it might be more steps, but they're not as tall and they're wide enough to get the person and their walking aid on them. Now, I understand that that might mean future adaptations if the person progresses to needing a wheelchair outdoors, say, for example. But my concern with going straight to ramp on the basis of future proofing is that actually, in my experience, and like I say, this is just my own clinical reflection, for that period of time where the person is ambulant, you're actually increasing the risk. So be really careful about what you're recommending there within steps and ramps. I'll come on to some of the legislation about that later. So regardless of which you're thinking, where to go to get some guidance on what they should look like. So adaptations to maximize independence and dignity. So things like height adjustable workspaces. So if the person's can stand or whether they're needing to sit or perch for a period of time, if they get particularly fatigued. Widen doorways in some instances to help with walking aids, whilst remembering that because part of your activity analysis will cover what does the person use to maintain their balance. And if they're actually someone who holds on to door frames, just be very careful if you're recommending widening them, will the person still be able to do that? And if they can't, what are you going to do? What are you going to put in those positions so that you're not in that short-term period increasing the risk? But in general terms, housing design, I think often internal doorways are too narrow anyway. So widening them to support access with walking aids and wheelchairs in the future is an option. A bit like the last slide, I put bathing versus showering in there just to really stimulate the discussion. So don't assume that a wet room or the level access shower is the way to move forward immediately. And the reason I'm saying that is nothing really to do with safety. It's around what does the person find meaningful to them. Let's not forget we're occupational therapists, or most of the people watching this, I expect, are occupational therapists. And it's therefore important that the assessment we're conducting is occupational focused. Ask the person what's meaningful to them and then try and solve that problem. There's no reason actually given the marketplace why if somebody finds bathing meaningful to them, they can't bathe safely with Parkinson's. Color contrast. So using color contrast, so with a light reflective value of greater than 30 for spaces, so flooring to walls, and to identify specific spaces within the bathroom or kitchen is a good way of identifying what the person does functionally within that area. Some of these can slide over into safety as well. And something like that with the color contrast, that stands again for someone with a visual impairment or someone with any other kind of dementia. And assistive technologies, it's being aware of things like the Sure stopcock, for example, a very low cost adaptation that would form part of another bathroom adaptation, but it means that the stopcock is just like a light switch. So it's there for someone to flick on and off as required. What means if something is overflowing or there is a leak in the bathroom, that person with Parkinson's can just quickly access it and switch it off. So it's thinking about that person maintaining their independence, not just occupationally within the bathroom, but actually being able to solve problems for themselves moving forward. The last thing you want is someone having to scramble around for the old style stopcock, which is under a sink somewhere and has probably seized because it's never been used. So that sort of assistive technology makes a big difference to someone in terms of their anxiety about how they move forward. And the wash dry toilet, for obvious reasons, it washes the person, it dries the person, maintains dignity, and maximizes independence. One of the things within there I just wanted to briefly mention, and I see it all the time, is that often somebody will have the recommendation of a rise recliner armchair, because someone with Parkinson's often struggles with that transition, not to push up into standing, but that transition from that lean at say 40, 45 degrees and into a full stand. So the obvious solution for that person, for their independence, their safety, is a rising armchair, which will help them stand up and supports that transition into a vertical stand. So you'll see that great recommendation and it's been put in place in there. And then around the toilet, there's a freestanding toilet frame where they have to push up into standing. And I get confused about how we don't make the link between the stand in an armchair and the stand in a toilet. If from an activity analysis perspective, someone struggles with that transition into a vertical stand from their armchair, why they're not going to struggle with that on the toilet? Putting something for them to just push vertically into standing isn't going to solve that problem. So it's being aware of what's available on the marketplace. As you can see from that video there, Closomat do two different products. So they do the Aerolet vertical stand, which you can see the video of here, but they also do the tilting stand, which will, just like a rising armchair, will help get somebody up into that standing position, negating the challenge they might have with transition from 45 degrees into standing. And then that helps that initiation into a good stride. So something really simple, cost effective and important to consider for somebody's transfer with Parkinson's off the toilet. And of course, it's completely compatible with the Palm Vita, as you can see there. We've written an activity analysis and toileting guide for everyone through Closomat, and it's on their website. I've put a screenshot of the front cover there. So there's more detail about activity analysis, specifically things around toileting and some of the things we might recommend from adaptations perspective for somebody presenting with certain elements within their activity analysis. So it's worth taking a look on the website. I'm sure when Closomat sends you out the link to the webinar, I'm sure they'll be able to also send you the link to where you can find this on their website. So I just briefly want to touch on some legislation, because it's all well and good talking about what modifications should be considered, but very different looking at how you justify them through legislation. So we're going to have a quick look at DFG through the Housing Grants and Construction and Regeneration Act. Very brief look at Approved Doc M and Approved Doc K, which is people are less familiar with. So Approved Doc M is around minimum standards for accessibility with large sections on wheelchair accessible design, but not just limited to. Approved Doc K are the building regulations for falls reduction. So there's some really important sections in there for us to be aware of, but again, people are often less familiar with it. And I'll briefly just touch on the Equalities Act to go back to one of my reflections on the Parkinson stages to think about where that fits. So DFG, the purposes are, sorry, this slide is the review document I'm sure you're all familiar with, which was published by, this guidance document was published by Foundations to support the Department for Levelling Up Housing and Communities. Hard copies are available at their events, but you can also get it from their website. It's a really good document, very easy to read, very supportive, and written in language that we all understand. It's really useful to have a look at. The purposes are to access the home and garden, making the premises safer, access to principal family room or bedroom, access to a toilet, access to a bath or shower, although don't forget DFG legislation says or both, if it can be justified, access to a wash basin, facilitating preparation of cooking of food, better heating, control of power, light and heat, and caring for others. Just want to put that in. So what are occupational therapists assessing? I've put that in because I think in reviews that we conduct for local authorities, or in particular ombudsman reviews that we have ongoing at the minute, we can often blur the boundary, and authorities can often blur the boundary about who's responsible for what. So it's just to clarify, occupational therapists are determining necessary and appropriate. We're not determining reasonable and practicable. It's necessary and appropriate. So we make recommendations based on what we think the person needs, wants, expects, and what will meet their current and long-term needs. That's necessary and appropriate. And I've put this in just to remind ourselves that for people with degenerative conditions such as Parkinson's, further adaptations may become necessary at a later date. So I've put this in around future-proofing. It's to remind ourselves there's no restriction on successive applications for DFG at the same property. In such cases, previous contributions will be taken into account. And it's why we should encourage, wherever we can, people to apply for DFG, even if they know that there's going to be a nil reward, because what they've spent will be taken into account on future cases. If they don't apply because they know they're going to pay for it themselves, then it won't be. But if you get that nil award and it says the person's going to be responsible for £10,000 worth of adaptations and they spend 6 on this, in future applications, that 6 will come off what they're expected to pay. So it's worth it being done, even if you know the award's going to be nil. But when we think about future proofing, and that's why when I mentioned steps and ramps, we know it can lead to more because of the progression of the disease, but that's okay. Approved OCM is the minimum standards for accessible design. So it covers access, egress, bedroom design, kitchen and eating areas, stairs, bathrooms, doors, hallways, parking. Really good document to look at as a starting point for design spaces, turning circles. When we're not technical designers as occupational therapists, then there may be some technical officers on this webinar who certainly are, but we ourselves are not. And it's a really good starting point for thinking about accessible design and what the minimum standards should be. And the same with approved.k, but it covers stairs, steps, landings, flooring material, ramps, and windows in relation to falls. So window securing and fastening, that sort of thing. But there are really good diagrams and drawings and guidance there around what stairs should look like, what the minimum standards for stair design should be, where banisters should be placed, where handrails should be, what flooring material should be used, what's classed as anti-slip and not, and the different categorizations. So we're often very familiar with DocM and less familiar with DocK. There are lots of things within there that we can use as part of our design and say, and reference DocK as where we've got that information from. So to encourage the evidence base to be particularly robust. And the Equalities Act. So yeah, so I put this in because I was reflecting myself just briefly when I was doing this on the first 2 stages. If they're not classed as, even having a low, never mind moderate impact on function, where does that leave us in terms of the DFG definition of disability? Because within it, it doesn't, the DFG guidance itself, it doesn't specify anything other than the person, it having an impact on the person's function in the longer term. But within the Equalities Act, some impairments are automatically treated as disability, even if they don't have an effect on day-to-day activities, including cancer. If you're certified as blind, severely sight impaired, or partially sighted, have a neurological degenerative condition. So it gives the example of MND, I think it is, in the Equalities Act, but it's any neurological condition, that degenerative condition, such as Parkinson's, being HIV positive, or having a severe disfigurement. So the person, after having that diagnosis of Parkinson's, automatically meets the disability criteria element of DFG. So I'm going to stop talking there now, and we'll open it up to any live questions.